elbow exam, and of all the exams, it's pretty much the easiest. It's just a hinge joint that moves back and forth. And so, again, the first thing that we always do is observation, where we ask the patient where it hurts, and we just look for areas of swelling, either medially or laterally, bruising, abrasions, etc. And then we usually have the patient move the arm themselves, so we'll have them extend it fully and see if that causes pain. And in her case, you can see that she can actually hyperextend the elbow just a little bit. Then we'll have her flex it and show us how much she can get with range of motion. Then we'll have them do supination and pronation and make sure that they have full range of motion that way with the radius moving back and forth over the ulna. Then we'll have them do strength testing. So we'll have them make a bicep and we'll resist, and then a tricep and we'll resist. And then again, we'll shake their hand and have them pronate the wrist down and supinate the wrist up, and just seeing exactly how good their strength is and what exactly hurts and where. Now we've done observation, range of motion, strength testing. We're going to start with palpation. And you have your triceps tendon come down, attaching on your olecranon process or olecranon tip. Then you have the lateral epicondyle, you have the radial head, and you have the olecranon tip. And between this triangle, you have the lateral joint line in this little circle. And that's where you're going to look for swelling. Some people think that the lateral joint line is up here, but it's really this little circle in the middle of the triangle. And the elbow has to be at 90 degrees to identify that. The hardest thing is to identify the radial head. And the easiest way to do that is to just put your finger there and supinate and pronate the wrist, and you'll feel the head moving underneath your finger. Then when you go to palpate the medial aspect of the elbow, again you have the olecranon tip, the medial epicondyle, the ulna, and this green line represents your ulnar nerve or your funny bone going down along the ulnar groove or the cubital tunnel, and then the purple marker represents the ulnar collateral ligament, which goes between the ulna and the medial epicondyle. And that's the Tommy John ligament that gets replaced during Tommy John surgery. Then in the front you have the biceps coming down, and if you have them flex against resistance, you can easily feel the biceps tendon. When the biceps ruptures in the shoulder and makes the Popeye muscle, we don't normally fix that, but whenever you have a biceps rupture distally, that's always a surgical problem. So now once we've done palpation and we've identified where we think the problem is, we do some more specific tests, and one is the Tinel's test, where we'll tap on the ulnar nerve and see if that gives them numbness down into their fourth and fifth fingers. Then one of the next specific tests that we'll do is we'll test the ulnar collateral ligament and see if that causes them pain when you stress that ligament. And so the easiest way is to have the patient do the milking maneuver, where they take the one arm underneath the elbow, grab the thumb, and pull it down, stressing the ulnar collateral ligament. And another way to do that is what's called the moving valgus stress test. And you take their arm up into the throwing position, in this position, the left arm, and you externally rotate the shoulder until it's stressed. And then you put your finger over the ulnar collateral ligament, and then you flex and extend the elbow. And you want to see if that causes them pain. And usually it will cause them pain in an arc from about 120 to 60. And then when it's fully extended and fully flexed, it won't. But stressing it through that motion is what will cause a positive moving valgus stress test. Once we've done the moving valgus stress test, the last specific test that we do is to look for impingement of the elbow. And usually the elbow will impinge when it is straight. And it's, again, like biting your cheek. The tissue or the synovium or bony pieces will get pinched in the elbow when it gets extended. And so we basically just do a hyperextension test and see if they get pain in the back of the elbow. So now we've done inspection, range of motion, strength testing, palpation, and specific tests, and this will conclude our exam of the elbow. This is our last exam. We're going to do the shoulder, but we're also going to include the neck. And we have a new model, Dr. Meshke, here to do the shoulder part of the exam. It's easier to have a male when you can take their shirt off. Usually with the females, we'll leave them in a sports bra or in a halter top or in a gown with the back open and the front covered so that we can see their scapulas better. So the first thing that you normally do is observe, and you're going to look for swelling of the SC joint, the AC joint, around the biceps, the coracoid, and you're going to turn them around and observe the position of the scapula and see if there's any tilting of the scapula, and oftentimes the inframedial border or the entire medial border or the supermedial border will wing or it will go laterally. And you can measure the distance between the thoracic spine and the borders of the scapula to see if the position is the same or different. So we'll turn them back around, and then we'll have them do range of motion. And so usually we'll have them do flexion, and you want to do both at the same time so you can see what their range of motion is, and then abduction, and then up in the 90-90 position, you do internal rotation and external rotation. And they can cheat on this with their shoulder blade as it will wing a little bit. So sometimes the best way to do that is have them lay down on the table, and the table will stabilize their scapula, and then you can measure their internal external rotation more accurately. Another way to do this, we'll have the patient turn around and do what's called the aptly scratch test, and you'll have them do abduction, external rotation, do both arms, and you'll notice that his dominant arm normally doesn't go lower, but in Matt's case it does go lower. But usually that dominant arm will not go as far down as the non-dominant arm. And then you'll do adduction, internal rotation, and you'll kind of just mark their range of motion. Another way to do internal rotation is to have them put their arm behind their back and push off to measure internal rotation. Okay? So now that we've measured motion of the shoulder, we can also measure motion of the shoulder blades. And you'll have the patient raise their arms into forward flexion all the way up over their head. And you're watching the borders of the scapula to see how they move. And you watch them and you have them go down very slowly. And you'll see Matt's right arm wings more than the left arm. Then you do the same thing in abduction. And you'll see his shoulder blade wings a little bit more here on the right. And then down. Again, you can see it's winging, and they're not moving together at the same pace. So now we've done range of motion. We'll turn them back around. And we'll do strength testing. So you can normally do deltoid. We have them push up. That's C5. You can do biceps, where you resist their biceps. That's C5. You can do triceps, which is C7. You can have them raise their wrist up in radial deviation. That's C6. You can have them extend their fingers out, and that's more of a C8, T1 distribution. Other strength testing that you can do is wrists up, wrists down, testing the various nerve roots. Moving on to rotator cuff strength, you can have them, usually want to test both at the same time, but for the camera we're just going to do one at a time. You do supraspinatus testing, so if you take them straight from the side up 30 degrees, now you're in the same plane as their shoulder blade lies on the back of their shoulder or back of their chest wall, and you have them flex straight up and down and test supraspinatus strength. Then you can put their elbow at their side and have them push out against your resistance, and that's infraspinatus and teres minor strength. Then you can have them push in against resistance, and that's subscapularis strength. Another way to test infraspinatus or internal rotation strength is again that push-off test from behind. So now we've done observation and range of motion and strength. So then when they complain of different pain in different areas with either motion or with strength testing. We'll start to palpate those areas. And the first is the SC joint, sternoclavicular joint. Then we'll work out along the clavicle to the AC joint, the acromioclavicular joint, which is usually pretty easy to feel. Then if you just grab someone's shoulder, your thumb is usually over their coracoid process where the pec and the biceps are attaching. Then you can feel the biceps groove between the greater and the lesser tuberosities. And oftentimes I'll do it from behind like this and just internally, externally rotate the finger and you'll feel the biceps move back and forth. You can feel along the humeral head. You can feel out along the acromion and then back along the spine of the scapula. And then you can feel for trigger points, which are often along the medial border of the scapula. You can feel up along the spine to make sure they don't have pain along their spine. Okay? So that's palpation. Now we should have a pretty good idea based on their history and their exams so far exactly what the problem is, and so we can move on to specific testing. And one of the problems that we often see is impingement syndrome or bursitis, and so we can do what's called the Neers test, where you have them put both their arms out front, thumbs down, and you have them raise their arms over their head and see if that reproduces their pain. Then you can have them do what's called the Hawkins or the Hawkins-Kennedy impingement test, and you keep the shoulder in the same plane as the scapula, and then you internally rotate and see if that causes pain. So those are impingement tests of the glenohumeral joint and the bursa. Then the impingement test for the AC joint is the cross-adduction test, where you basically stretch the posterior structures and impinge the AC joint. That's also called a scarf sign. Looks like a scarf. So those are impingement tests for glenohumeral joint, bursa, and AC joint. Then we can do apprehension test, and if someone has subluxed their shoulder or had a dislocation, usually it's when their arm's in this position. So if you put them in abduction and external rotation up here, they'll often feel like their shoulder is going to go out or it's painful. So that will be bothersome for them. Then if you put your hand in the front of their shoulder and give them the support that they don't have from their anterior capsule, that's called a relocation test, and will often make them feel better. Then if you let go again, they'll often feel worse, and that's a positive apprehension test if there's pain or a feeling of instability, and a positive relocation test if they feel better. You can also do a test where you pull their shoulder out this way, and that can reproduce and make their symptoms worse as well. So now we've done apprehension and impingement tests. We can move on to laxity tests. And some people are just loose jointed. They can bend their thumb down and touch their wrist. They can bend their little finger way back past 90 degrees. They can put their palms on the floor. They hyperextend their elbows. And those people often have shoulder laxity as well. And the way to do that is you have to, I'm going to turn you, put your forearm on their shoulder blade to stabilize it, and then grab the humeral head with your other arm, and then the shoulder joint doesn't sit straight at this plane. It sits at a 30-degree angle forwards. So you want to push forward and backward in that plane, feeling for how much you can move the humeral head. And that's anterior laxity, posterior laxity, and then you do what's called a sulcus sign, where you pull the shoulder down. And Dr. Meschke doesn't have one, but you'll see a divot form like a suction mark right here. That's called a sulcus sign for inferior instability. And if you're looser on the affected side than the normal side in two of those three planes, that's called multidirectional instability. So now we've done laxity testing. The last thing that we want to test for is labral pathology. And there's probably 30 tests in the literature for that, and we're just giving you a few tests that we often use in our practice. So one is the O'Brien's test, and you have the patient forward flex their arm to 90 degrees, adduct it about 10 degrees across their body, and then put their thumb down and push up. And you see if they have pain. If they have pain at their AC joint, it just means they have AC pain. If they have pain deep in their shoulder where they can't really get to it, that's positive labral pathology. So then you do the same thing, 90 degrees flexion, 10 degrees adduction with their palm up, and you have them push up. And if that causes less pain than thumb down, that's a positive O'Brien's test. If they both hurt, it's equivocal and doesn't really mean anything. Another test is the crank test, and that's looking for a labral test that's superior on the labrum. And you have their arm up here in about 30 degrees of forward flexion, 90 degrees at the elbow and the shoulder, and you push into the shoulder joint while you're internally and externally rotating the shoulder. And you see if this reproduces any painful clicking or popping. Another one is the exact same 90 degrees flexion, elbow bent 99, but instead of pushing in this position, you're pushing backwards from a flexed position and internal external rotating, and that's called a clunk test, and that's looking for a posterior labral tear. That concludes our tests for labrum. Now we're looking more at biceps, although some of the biceps tests can also be positive for labrum pathology. So a Speed's test is you put their arm flexed about 30 degrees, abducted about 60 degrees, and you palm up, and you just have them push with their arm straight up, and you see if that bothers their biceps as it attaches onto their labrum. Another test is Jurgensen's test, which tests specifically for bicep groove pain, and you have them in a 90-90 position with their arm straight ahead, and you have them supinate or turn their wrist this way against resistance, and you feel their biceps groove to see if the tendon subluxes out of the groove. So once again, we've finished with observation or inspection, range of motion, palpation, strength testing, and specific testing of apprehension, laxity, the labrum, the biceps, and impingement. And the last thing that you want to do is make sure that the shoulder pain that they're having isn't radiating from their neck. And so one way to test that, we've already tested the strength of of different nerve roots when we did our strength testing, but it's do a Sperling's test. And basically, you have the patient pull their neck like a chicken. Instead of going out, you have them pull it back, and then you have them rotate it like they're looking in the corner of the room. So rotation and extension of the neck, and then you push straight down on their head. And that mashes their facet joints together and may impinge the foramina where the nerves are coming out. And then you do it to both sides. And you make sure that you don't reproduce their shoulder pain that's coming from their neck, and that's called Sperling's test. And once you know that you've examined the shoulder, you've examined the neck, you could finish up with your exam and be pretty positive exactly that you've done a complete exam. So that concludes our physical exam joint series.